What are the most useless tests that are routinely ordered in the hospital? This person's vote is for urologists who order routine surveillance imaging on benign renal cysts in perpetuity. It's a test that doesn't even have a chance of being clinically useful. So I'm very curious what this person does, because this is not a situation that comes up to me all the time. Is this like a PCP or something? Because I feel like I've never run into that situation where I was like, oh man, I really feel like urology was ordering too many imaging tests. This person says, reminds me of giving lactulose to a hepatic encephalopathy patient and then testing them for C. diff when they have diarrhea. I'm surprised you're allowed to do that. Where I am, one of the requirements for C. diff testing is the patient cannot have received any laxatives in the past 48 hours. That's also the same at my institution, although you can override it. But you have to I acknowledge this is a low yield, low value test in this setting. So basically, if the patient is on tube feeds, or they have laxatives, or they have a strong alternative reason for their diarrhea, those are all situations where it makes you click to say yes or no. And then if any of those answers are yes, then it says, oh, this is a low yield test. I am GI. The hospital fecal occult blood test is the most useless test in the emergency/inpatient setting. Please stop doing them. And yeah, there's this whole campaign, there's this whole thing on choosing wisely about not doing guaiac tests in the hospital. They've only been validated for use as a outpatient colon cancer screening tool. There's actually a whole campaign called It's Whack to Guaiac. And so it's trying to encourage people not to do it because the false positive rate for this test is incredibly high. If you're just doing a collection of stool and you're inserting your finger into a patient's rectum, that can cause bleeding. If somebody's on aspirin, they might just have a little bit of bleeding going on. And then if somebody has a clinically significant upper GI bleed going on, they're going to have melena. They're going to have hematochezia. They're going to have something that you are able to actually see. If their stool is brown and it's normal looking, then really that argues so strongly against a fecal occult blood test. And GI is always going to get angry at you for getting this because, again, it has low specificity, has a low positive predictive value, and it basically, they're never going to scope somebody based on the result of the guaiac. Our GI service requires it every time we consult them for a bleed. Yeah, that service is not up to date. Who is running your GI service? FOBT means fecal occult blood test. Occult means not accompanied by readily discernible signs or symptoms. If someone is bleeding, you don't need the test. You can tell just clinically if they're bleeding. They've got a drop in their hemoglobin that's rapid, or they have melena. If someone isn't bleeding, FOBT doesn't necessarily warrant an inpatient scope. Squeeze hard enough on a fart and fecal occult blood test is positive. Worthless test. Not to mention, if you're using the card test, certain foods and medication can make a false positive too. True, but I like the fart thing better. Another response on the same thing, stool guaiac, not good enough to be a diagnostic test or a screening test, yet people triumphantly tell me this over the phone as if it clinches some diagnosis. I do not have the heart to tell them. He should tell them. He really should tell them. It's whack to guaiac. I mean, there's so much evidence about why it's completely a worthless test in this scenario. And also, going back to this comment here, our GI service requires it every time we consult them. I think what they're really requiring there is they wanted to make sure somebody did a rectal exam or looked at the stool and actually said if it was melena or not, or if the patient was just reporting it was melena. You can do a rectal exam and just get some stool and see if it's melanic or not, or if it's brown. That's useful for the GI doctors. And a lot of times when the nurses message me, say, hey, patient had a bowel movement. Would you, like to come take a look at it? I'm like, yes, I'll come take a look at it. I also want you to take a picture of it, or I'll take a picture of it. And so I can put it in the chart so GI can see it, because they do like to see what the stool actually looks like. And that actually does make a big difference for their planning. I'll never forget my first or second night shift rotation when a nurse called me about maroon stool with visible blood in a patient with a known GI bleed. Do you want a fecal occult on it? You literally just told me there's blood. I think the occult has been ruled out. Maybe there's some extra blood hiding among the visible blood. I have not done a rectal in almost a decade. Either it's a clinically significant bleed and the patient will need a scope anyway, or it's not clinically significant and no GI consult is necessary. An awesome GI fellow broke this down for me in residency, and yet so many still ask for a rectal. I assume to appease their attending. I always refuse, haha. It's very interesting. There was a little bit of a debate here, it looks like, in terms of what, people thinking that it is useful, people saying that you're right, it's not useful. So very curious to hear what you guys think here. Daily chest x-ray, if no new lines or tubes or significant clinical deterioration, probably do more harm than good given the incidence of techs, RNs, dislodging tubes and whatnot. These dailies are so painful they need to be removed from the ordering set. Indication tube placement with all tubes and lines removed 5 days ago. No lines or tubes visualized. Yeah, that must be so frustrating for a radiologist. I will say that when I was doing training, we did practice the daily chest x-ray, and it is kind of nice to have something to look at every day and make sure that something didn't happen. But I do agree. I made a guide on Reddit for ICU, taking care of ICU patients. And I wrote daily chest x-ray there, and I got a lot of pushback back on it. And I do see how it is kind of a waste when nothing has really clinically changed about the patient. What are we really doing with this information? What are we really looking at by getting these daily chest x-rays? Here is what I and all radiologists I know dictate on these Bosniak 1 and 2 cysts. No follow-up imaging is recommended. Then it stops. So yeah, this person at the very top, they must be a radiologist, and we found out their specialty. That's why this was their specific complaint about getting too many renal cyst things. ANA as an autoimmune rule-out test. Headaches, you get an ANA. Stomach pain, you get an ANA. Now, I feel like this has really, at least where I've practiced, this is not a thing. People really, really talk themselves out of getting an ANA in all scenarios because this point is belabored so much. People are always saying, oh, don't get an ANA, it's so non-specific, it's not, it's just like kind of useless. A lot of people have like mildly positive ANA. And so it's kind of like the CRP. Like people nowadays really hesitate to get a CRP because like, what is it really going to change, right? In those cases, I still do get CRP sometimes if I'm trending something, like patient with like osteomyelitis, they really like getting CRPs to trend it. But these are some tests that people don't order that much anymore because I think we've hammered it home so often that it's really not a great test to get. Maybe that's just a side effect of being at an academic institution, and maybe this happens a little bit more in the community. Daily CBC in everyone, and make sure it's always with diff on a normal white blood cell count we've been ignoring for a week. Yeah, so our hospital actually used to do CBC with diff on everything, but now all the admission sets have CBC without differential. And so it makes it a conscious choice to say, I want a differential on this one. And I think that actually has really been a good thing. I don't know how much money it's saving or resources it's saving, but it totally makes sense. We don't need a daily differential every single time. If we have a question, get that differential, but no differential is much better. I will say daily CBC and BMP, we still get it a lot in our medicine patients. They just get AKIs. They get like anemic randomly. And we like still check it when they first come in, it's, they were recently admitted. Once they become like a placement patient, then we do, okay, maybe twice a week or once a week. Cause at that point, they're just kind of waiting for placement. The thing that people are definitely afraid about is not noticing that the CBC fell off or the BMP fell off and then maybe missing a couple of days that the patient's been developing an AKI. But I don't see that happening too often. So probably, yeah, we definitely need to be reducing some of these daily labs so much. We're just like phlebotomizing all the patients and waking them up at 5 a.m. every day. Ammonia. Elevated doesn't rule in hepatic encephalopathy. Normal doesn't rule it out. What on earth is the point? So yeah, he's getting to the point that when we're looking up a patient with altered mental status, their ammonia could be high, and that doesn't mean that they're altered from hepatic encephalopathy. And if it's low, they could still have hepatic encephalopathy. That's basically what he just said. So the only times that you do get it really is if you're concerned like a brain herniation could happen. If the ammonia is greater than like 200 or something, that could actually give you a clue that herniation could be, or cerebral edema could be a significant complication. Sometimes when we're really just lost and just can't figure out anything, and there's no signs of cirrhosis, we do check it. There is like Depakote-induced hyperammonemia. There's like random medications that can cause it. So you may see it in patients that you wouldn't otherwise typically expect it in. But yeah, in general, we do frown upon getting an ammonia. New onset altered mental status is when I order it, or people who are altered who take valproic acid. So exactly what I was talking about. Urine culture in patients with no urinary complaints. LMAO, yeah, you're definitely a PharmD based off that alone. My answer is either urine culture or C. diff. Can't believe no one has said strep swab in someone without symptoms of strep. I haven't really seen that much in the inpatient setting. Why has no one said CRP ESR except rheumatology? Y'all are cool, you can keep it. Us inpatient schmucks seem to order it left and right, and it tells you what? The patient is inflamed? They're here with urosepsis. I would think they would be a little inflamed. Sounds like this user is a little inflamed. This attending is a little inflamed. Oh, the other good time to use it is if you're concerned for necrotizing fasciitis or necrotizing soft tissue infection, used in the Lurinex score to calculate that. It's interesting to see how wildly different medical culture can be in different places. In Sweden, CRP is king. Everyone gets a CRP. Kid in primary care with maybe signs of infection, CRP. There's even machines for point of care CRP. You step within a foot of the ER, CRP. You're inpatient for urosepsis, CRP. It's CRP all the way down. Yeah, definitely, I have some family members who live in China, and like anytime they go get any routine blood work for anything, it's like every single possible lab that you can order, it's all ordered. And then, when we take the cat to the vet, they're checking like on top of the LFTs, they're getting a GGT every single time. It's like they throw like basically everything at it. So it's very interesting. But then it goes to show you, these other countries, they're throwing on so many more labs, so many more tests, and yet their costs of healthcare are so much lower than the US. So we're trying to do all this cost-conscious savings, but who are we really saving the costs for? It's for all these administrator people who are making the big bucks from hospitals, and all the black suit people who are like, oh, these doctors need to stop spending so much so we can make more money. And that's why the cost of healthcare in the US is so high. That's just my really brief rant and opinion. I don't know how exactly validated my reasoning is, but that is how I feel, definitely. You would think the way that we do practice stewardship and high value care, we would have lower hospital costs than these other countries, but we don't. And it's because there's hospital costs from other things that are really bumping up the costs. Step 3 is the most useless test that is routinely ordered. I like that one. Magnesium as a routine daily lab on most inpatient units after the big ones like CBCs and BMPs. Magnesium is the most frequently ordered inpatient lab, ordered as a set and forget daily lab in our system. Yeah, I think only really needed for people who you're looking at, severe malnutrition, and like arrhythmias, high risk for arrhythmias, heart failure patients, things like that. This person says urine drug screen, lots of false positives, and it doesn't detect a lot of drugs that are commonly used. PCP, they said they just do a CMP and lipid panel every few years, but you go down the hallway and somebody's getting CMP, lipid, CBC, TSH, vitamin D, ABC, XYZ. Procalcitonin, I agree. Procalcitonin, is really only validated for knowing when to stop antibiotics. And then even in that scenario, we already have pretty designated times for stopping antibiotics. For example, for pneumonia, we treat for 5 to 7 days. Why do we need to trend the procalcitonin? The procalcitonin studies were done in patients who were getting like 14, 21 days of antibiotics, and it was helping them guide when to stop antibiotics. So really, the procalcitonin is pretty much useless. But I will say I still like to order it a lot too. I mean, I don't know. I am curious to hear what your guys' thoughts are in practice on procalcitonin is. So yeah, if you look at the PRO-RADA trial, which was using a procalcitonin-guided antibiotic strategy, the antibiotic days in the control group was 14, and the days in the procalcitonin group was 11 days, both of which are higher than our standard recommendation of 7 days for ventilator-associated pneumonia or hospital-acquired pneumonia. So, this is kind of an obsolete study. It was done in 2010, which is not that long ago, but our practice is already to give less antibiotics than the patients in the study received anyways in either group. AP and lateral lumbar spine and cervical spine have a low yield. They're often ordered as a screening tool for back pain, but are rarely helpful because they are not sensitive tests. I would suggest, if you feel inclined to order, to at least do so with a flexion and extension to evaluate for instability. But how else will you tell your patient they have the worst back you've ever seen and they need a laminectomy and fusion stat? Sacrum coccyx films are even worse, totally useless. Yeah, I feel bad every time I do order something like this, but a lot of times it's the patients really adamant that they want some form of imaging. And I guess in the effort to minimize the radiation risk to them, instead of getting a CT or something, or doing an MRI, which is much, much more difficult to obtain and much more costly. Just getting an X-ray can be helpful to just give them some reassurance. That being said, it would be nice if we could just give reassurance and convince them not to get the imaging test. But just the way the hospital climate is, we're almost, physicians are almost like in a customer service role. And like if somebody's really, really demanding an X-ray, it's hard. It can be hard to convince them that, you can't give it to them, for example. I'm sure a lot of you guys have run into that conundrum yourselves. Vitamin D level. Tests cost way more than the treatment, and nobody gets symptomatic hypervitaminosis D. Just throw vitamin D at them. So this is interesting because we're actually, there's a choosing wisely against folate because if somebody's folate deficient, it's more cost effective to just give everybody empiric folate if you're suspicious for folate deficiency than to test for it. So this sounds like it's a pretty similar thing. At our institution, we actually check vitamin D a lot because depending on how low it is, we do give different doses of vitamin D. So in that sense, for our osteoporosis and fracture, fragility fracture patients, I do still feel like it is useful to check the vitamin D level, but I can, totally see where this person's coming. What are the inpatient tests that annoy you guys the most? Let me know in the comments down below. I'll see you in the next video, and thanks again for watching. Peace.